Chapter 32, Safety. In factors that affect safety, if we think about age and development, that's an important thing. The very young, if we think about our infants and toddlers and preschoolers as they're discovering the world, a lot of times they touch everything and they put everything in their mouth, and that can present quite the hazard. For the very old, we think about as everything slows down and diminishes, especially our sensory and our neurological status. They might have balance issues. They cannot sense things that may be very hot or very cold. They may not be able to taste things if they are expired food products or different things like that. So a lot of other concerns about them just trying to slow down and be a lot more careful about their environment around them comes into play. As far as lifestyle, you have to look at both the work and the home environment. I think of the home environment with that third bullet point, insufficient funds, is do they have funds to purchase safety equipment or to make home improvements so that their environment truly is safe? If they are now wheelchair bound, do they have money to make sure that they can have a ramp into their home? Do they have doorways that are wide enough? Are they able to purchase, eyeglasses or a walker or a cane, whatever it may be, as far as that goes. With the work environment, you think of hazardous materials, whether that may be fumes or chemicals. If it's in a bad area of town, are they working the night shift, different things like that. Access to firearms and illicit drugs, we can just think of all of the trouble that can go, especially if those two are mixed together. Another thing with lifestyle that popped into my head, even the state of Tennessee is taking recognition as far as if you are on the government healthcare plan, you have to complete a survey every year. And one of the questions that they ask is, do you feel safe in your neighborhood to walk outside at night? Just trying to get at where, not necessarily where do you live, but do you feel safe? Do you feel like you can exercise in your environment? Do you feel threatened, or just to go along with that anxiety and exercise and health overall? Mobility and health status. All of these things that are mentioned: paralysis, muscle weakness, diminished balance. If we think of all that, it will just increase our risk of injury, the likelihood of falls. And so we do need to pay attention to all of those musculoskeletal and balance issues when we think about that. When we think about sensory and perception alterations, if you lose any of your senses, so think about sight, smell, hearing, touch, taste, any of those is going to alter how you perceive the environment around you. Kind of like my example before with our geriatric crowd and maybe some of the sensory decline that they have. But that's just going to come into play there. I was walking downtown, and I saw a gentleman, and he was walking his dog, and they had it was from Christmas, even though it's not Christmas, but it was just a collar they put around their dog that had bells on it. And this can happen in people that don't necessarily have sensory perceptual alterations. But they had done that just because animals, a lot of time, if they like to be right around you and right underneath your feet. If you have any alterations, balance, or if you just don't see them, they can become a great trip hazard. And so they had put that collar on their puppy so that they would be able to kind of hear where the dog was and help with them not tripping and falling over their dog. I thought that was kind of a great way to cope. Cognitive awareness, if you think about anything that's going to alter your ability to think clearly and to respond in a coordinated, timely fashion, drugs, alcohol, depression, lack of sleep, if we have any kind of disorientation for whatever that may be, if just mild confusion. We'll talk later about confusion that can result just with being in the hospital sometimes, and that has to do with the lack of sleep too, I believe. But anything that just would affect your ability to think clearly, process, have good judgment of what to do and how to respond, like I said, in a timely manner. And kind of tying along with that, the emotional state, so these extremes. So whether it may be A very stressful situation that could cause an error in judgment, a decreased awareness. Depression that I already mentioned comes into play. I know a lot of people, when we speak about chronic health disease issues, and I'm thinking about like end of life kind of chronic health. So if we think about cancer and at the end of life, or an untimely death, or death in any sort of situation, whether expected or not, a lot of times the loved ones that are left behind are really not able to think clearly for a period of time thereafter, just because of their emotional state. Other things that are going to affect our safety, our ability to communicate, whether they have aphasia, that ability to speak, where they might know everything that you're saying but be unable to communicate back to you. That can cause issues, and it could be the other way too. If they are not able to process what you have said clearly, a lot of times this happens with our stroke patients. You give them extra time, and sometimes they can cope, and other times not. Also, those language barriers. If you speak a foreign language that I'm unfamiliar with, I will have no clue what you are trying to tell me, even if you are telling me to run away. Nonverbals can help, but they are not as clear. Inability to read. A lot of times you'll notice in the hospitals we'll have signs, but those signs will also have signs with verbiage on it, saying warning or don't come in the room, no smoking, things like that. But they also have a picture on them, so that we are trying to communicate and reduce those barriers to communication. Safety awareness, so any information crucial to safety, think about prevention here. So we just want to make sure that our patients, they know everything they possibly can about their environment, about any equipment that we will be using with them and for them, just so that they can be aware and informed and make good choices, and hopefully nice, safe choices, that they would adhere to whatever safety concerns. I think of oxygen as just the big one here. With oxygen, you want to make sure, since it is explosive, that there is no smoking around the oxygen. And a lot of times people don't adhere to that, and so we want to make sure that we're not going to have any sort of fire around that, especially in the home environment. With environmental factors, if we think about the healthcare, a lot of times we have diagnostic errors. We have false positives and negative positives when they should be a positive. Trying to think of how to say that. But a lot of times they are really not intentional. So we really work hard to not have these. In your book, it references the Institute of Medicine and their report to err is human, and that culture of safety that we're trying to do. A lot of things were more punitive in the past. Now, like we had talked about this past week with documentation and incident report filling out, it's really trying to understand the cause of the problem, to not be punitive in nature, to help figure out, to support the nurses, and to provide the best possible environment and process so that errors do not happen. This domino effect, this last bullet point, is just saying if we are safe as nurses and we administer safe care, then our clients, our patients, that they are usually going to be a lot safer and to not have unnecessary errors. If we do everything we should, we're going to reduce the likelihood of falls. If we do everything we should reduce the incidence of hospital-acquired infections. If we're practicing good hand hygiene and things like that. With workplace, I think of OSHA and all the standards that they have out there, but just there is a policy and procedure and a handbook and a guide for how to deal with every chemical, for how to deal with every machine or equipment that we come into contact with, IV poles, EKGs, and everything else. I'm trying to make it specific to us. Fatigue, if you go to work tired, there is a greater likelihood that there will be safety issues and safety concerns, and that goes along with lack of sleep and just having a clear judgment where you have good reaction time. Noise and air pollution, I think of noise more so than air pollution for us in healthcare. There is a big push right now, especially from Joint Commission, our accrediting body for all of the hospitals and healthcare agencies, To deal with alarm fatigue, especially in the ICU setting, telemetry monitoring floors, things like that, there are alarms that will constantly go off. And a lot of times nurses are becoming desensitized to these alarms and not responding in a timely and appropriate manner. You will see, at least at Memorial this semester, you'll be able to differentiate by the end of the semester some of these different alarms, and you will know which alarm is the bed alarm, and you will know which alarm is more for a code situation if we have that on the floor, because you will see people running and responding very quickly, and hopefully you will also take part in that responding very quickly if you are in a place geographically and just whatever is going on in your world with your other patients at that moment. If you're able to respond, that you will. I think this slide speaks for itself. So if we're talking about the home environment and you think about what is safe, well-maintained flooring and carpets, if you have throw rugs, maybe getting rid of those. I mean, anything that might be a trip hazard, like that. Non-skid bathtub or shower, so just to have, so it's not super slick and you go sliding, especially once your feet get soapy there. Fire safety and planning and alarms, just to have the smoke detectors, carbon monoxide detectors, whatever that may be, to have a plan in case of a fire. Where would you go and where would you meet your family? I mean, all of those different things, just to make sure that there is a plan. Depending on environment and where you live, hopefully where they have earthquakes, they have plans in place at home and at work as far as what to do in the event of an earthquake, to take cover somewhere. Community, and here, sorry, going back to the planning, I think about tornadoes, right, in the southeast. So do you have a plan of where you would shelter in place, finding that interior room on the lowest floor without windows there. Community, so street lighting, safe water, sewage, regulation of food, sanitation, all of these things that keep us safe in our community that we have already talked about. Other environmental factors to consider, bioterrorism. The agents are divided into categories A, B, and C, depending on how easily they are spread from person to person. The rate of death and illness that may be produced, and just that morbidity and mortality. The big ones, Table 32-1 in your book, it's page 646. It talks about some of the different pathogens that we are most concerned about at this point in time for bioterrorism attacks. Smallpox, anthrax, Ebola, yellow fever, those are the ones that you may have heard of, or recently botulism is also in there as well. As far as disaster planning, we need to be ready, whatever the disaster may be, whether terrorist or environmental disaster, just to care for that. As far as disaster goes, in the community, you need to be prepared wherever your community is, whether you want to serve locally or nationally. And it's important that before a disaster occurs, we need to be prepared. And if this is something that would interest you, then it would behoove you to get in touch with a disaster agency that would respond, such as the Red Cross or other agency. And I just think of the Red Cross first here in town. And they will train you specifically for going out and responding to different disasters. The other important thing here is that we have to take care of ourselves. No one else is going to take care of us. We can get post-traumatic stress syndrome, stress disorder, PTSD, just as easily as anyone else when you might be exposed to disaster and whatever that may look like. I mean, it may be a hurricane, it may be a tornado, it may be a terrorist attack, and so just being able to cope and handle and figure out how we can cope and deal with our own stress and process these things is very important. With assessment, when we start our nursing process here, When you begin assessing for safety, all of these risk assessment tools, we're going to look at those and look at our patients' current activities and practices and use appropriate tools. So whether they are at risk for falls, whether they are at risk for any type of abuse or suicide, or there is a risk assessment tool for anything and everything under the sun pretty much at this point. We just have to find it. And that will help us to use these tools. They help you to assess and be comprehensive about your assessment. A lot of times they are being improved upon, and so we just look and make sure that we have the most up-to-date and best assessment. For home health, once again, so fires, falls, poisoning, suffocation, depending on the age of your patient, will depend upon what is most prevalent in their life. We talked about the IOM report to err as human briefly, and it's just the whole point is to help reduce harm and decrease morbidity, mortality with our patients as a result of errors, whether that's medication errors or general errors in the clinical setting. Like I mentioned, there is this one now with alarms, and so at the beginning, and it's alarm fatigue. So we really just want to be sensitive to check our alarms at the beginning of each of our shifts, make sure that the alarms are turned on, make sure that the volume is an appropriate level so that we will hear it and we can respond as needed. Joint Commission National Patient Safety Goals, these are a little dated. You have the updated ones posted for you on our Blackboard site, and these are very important because this is what we, as a result of being employed by certain hospitals and agencies, wherever they may be, this is what that hospital or clinical agency is being held accountable for. They have them for acute care, long-term care, surgical centers, ERs, it goes on and on. But that holds us accountable for whatever is most important and the biggest problem currently. These will change on a year-to-year basis. Sometimes they never go away, such as to reduce the risk of healthcare-associated infections. And then other times we may get really good at something and it may drop off of Joint Commission's list. So sometimes you will see the way that they are numbered may not be in a chronological order. Again, with assessing bioterrorism, so anything that seems suspicious, we just want to make a note of it. A lot of times get the health department involved or any epidemiologist involved so that they can see, is this revealing a larger pattern? And there are standards of what ERs and hospitals have to report to the health department so that these trends can be recognized and noticed in a timely manner. They're often looking for unusual clustering related by geography, by the number of ED visits with patients that have similar symptoms, an unusual age distribution if it's a common disease, and then if there's a large number of cases of acute flaccid paralysis. I jotted that one down. That one is suggestive of botulism. So if people are randomly having flaccid paralysis, you stand up and take note of it. Don't really know what else to say about that. Diagnosing. So this would be our next step in our nursing process. The things that would be relevant in relation to safety, risk for injury, right? So whether it is going to be risk for falls, latex, you can yada yada, read all that. Deficient knowledge, we want to make sure that we are promoting and preventing accidents and any other injuries as best we can. And there's one other on here, readiness for enhanced knowledge, accident prevention. So I think that was another one that was mentioned in your textbook. Next step of our nursing process, planning. So we just want to come up with a desired outcome. So this is our goal. Think of your major goal. We want to be able, with safety, we want to change health behaviors if they are unhealthy. We want to modify the environment if it is unsafe for any reason. And whatever outcome is specific for our individual, whatever they are at risk for or whatever they are experiencing that is causing them to be in an unsafe environment or an unsafe situation, then we want to see if we can do something to help with that. If I had to pick one thing that I wanted you to focus on in all of these chapters, it would probably be the implementation. This to me is most important because this is what we do. These are our nursing interventions. This is, we recognize a problem, so what? Now, what's next? What are you going to do? So to me, this is the application of the knowledge for you. So we are going to promote safety. What does that look like? We're going to observe, hopefully predict potentially harmful situations, help to avoid them. We're going to teach, share that knowledge with everybody. And then it depends on the lifespan. So where are they? So just to know, I think this is good. Page 647 and 648, it goes through client teaching based upon the lifespan. And I think that that is a good box to read. And I think that these next few slides summarize it. So if you have a newborn, what is important? Well, know that especially in that first year, accidents are the leading cause of death. We want to educate our patients to be very observant, to be very diligent and mindful of watching their children, especially once they are no longer just laying there, once they start rolling everywhere or crawling everywhere, or, you want to put plug covers over all the electrical outlets. You want to lock any harsh chemicals, put them up in a way where infants and babies cannot get to them. And that goes along with identifying and removing those common hazards. And it's also super important that if they are in a position to, we want them to know just some basic first aid. CPR for infants is fabulous if we can. I wish we could teach everyone. And then just what do you do if the infant decides to put something in their mouth and they now have an airway obstruction? So how to get rid of that. Most commonly with our newborns and infants, burns. A lot of times this can be signs of abuse, but it also can be just accidents. Bathtub water, we don't really realize how hot it can get to an infant and newborn skin, and so you want to be very mindful of that. A lot of children end up with burns as a result of hot bathtub water. Suffocation or choking, a lot of times with those plastic bags. Automobile crashes because they are not properly restrained. Falls because they're learning to walk and wandering around, and if there are stairs involved, it can get pretty dangerous. Poisoning because they put everything in their mouth and they don't know whether it's good or bad, and you have probably seen a Tide commercial or two where they are saying these little packets now that look like candy, make sure that they are put up far away because they do look like candy and it looks like something yummy, and it really is poisonous and can be very harmful and cause ultimately death if ingested. Toddlers, toddler proofing, because they are wandering around. They are going to fall, they are going to get hurt, but we want them not to be falling into sharp objects or hitting things too hard. Once again, restraints in the cars are very important. We want to keep those items away. I think I changed slides while I was still talking. Apologies for that. And then other things, lead. If you live in an old house and there was lead-based paint. Antiques are kind of a popular trend with some people, and they are just kind of part of when you inherit things. You have grandma's bed that was painted back in the 60s or 50s or whenever it was, and it may have leaded paint. So kids, you have to really ingest a lot to have an issue, but I have a friend right now and their child has very toxic levels of lead in their blood, and they're trying to figure out why. They have identified a bed at one of the grandparents' home that the child had been chewing on. She has a nervous tic, or I guess that's the best way to kind of explain it. There is an official terminology applied to what she has, but she likes to chew on things just to help calm and soothe her, even though she is 7 or 8 years old. And so she had been chewing on this bed, but they still haven't been able to identify exactly where else she's receiving lead from, because they have removed that and her levels are still very high. So they have taken her to a toxicologist in Nashville trying to figure out what's going on. Fumes from leaded gasoline. Sorry I went on about lead, just that's a part of my world right now. Anyways, you just want to keep them safe. Preschoolers, still maintaining environmental awareness of what is in their reach. Matches, medicines, other hazards. Some kids are very talented and they can get even through those prescription bottles of the child-proof tops there. My child just figured that one out. So, education as far as, just educating and even stashing them somewhere else if I ever become weary that he might consume things that could be hazardous. Vitamin D I think is going to be okay, although that could be toxic too. Preschoolers, once again, so safety education, how to cross the street, what are the traffic signals mean, wearing your bike helmet, and learning all of these rules of the road. Excuse me. I think our public school system does a pretty good job about this, but they are not the primary educators, so I think it's important, and I think our kids need to know it before they start kindergarten too, all these safety things. And so the parents just really need to remain very vigilant. Here again, we want to touch everything on our tippy toes. Is this hot or not? So a lot of times you'll turn your pot handles, oh, there it is on the top. Turn them inward to help prevent the kids from injury there. School-age children, you never know what they're thinking. Everything is real. So when they get into playing these video games, a lot of times they have difficulty, and it's just because of where their brains are developed right then, but difficulty differentiating between what is real and what is fantasy. And so a real gun may be very similar to the gun that they use on their video games, and they may not be able to process that actually firing a real firearm can cause death versus the video game where everyone, once you reset the game, everyone is back alive again. And so just that differentiation. They will imitate whatever their parents are doing or whoever their role models are. Superheroes, there have been many an injury caused by children jumping off of things and thinking that they could fly or land gracefully like whatever cartoon character they have seen do before. And accidental injury is the leading cause of death in this age group. School-age children still, accidental deaths, and these most frequently result from motor vehicle accidents, drowning, fires, and then firearm injuries. Minor injuries because they are superheroes, the swings and the bikes, the skateboards, swimming pools. And then we run into the adolescents. So here we are, they are looking for an outlet for stress, and they have just gotten their driver's license, so they will assert their independence, try to impress their peers, and run into, get themselves into hazardous situations where safety becomes an issue. The other thing are sports injuries. A lot of them are playing sports. I know football has become very aware of concussion injuries, and they do everything within their power to promote and prevent these injuries and to protect the head. And so they won't, softball even, just every sport is very, very cautious with concussions, and so making the players sit out for however long they may need to be. But there are other sports where those repetitive motions, they may just run into other injuries, whatever that may be. Competition, teamwork, conflict resolution. So there's a lot of different things, but I think sports injuries in general, just the concussions is just the big one in my mind, but then also like gymnastics and spraining ankles or wrists, different things like that. Suicide and homicide, these are the two leading causes of death in this age group. Influencing factors of these injuries, a lot of times economics, as far as do they have resources, Family dynamics may change and they might not know how to deal with those, and then also that availability of firearms. A lot of times we see adolescents and teenagers, they a lot of times are really trying to reach out and get help. They just don't know how to do that. So sometimes you may see cutting or other injuries, and a lot of times we just need to be very observant as healthcare providers to look for those and to make sure that we are treating the whole person. And so we are looking into that that mental piece, and making sure that they are socially healthy. Another thing here in town, a lot of times, and everywhere else, because if it's in Chattanooga, are the gang violence that we have. And so just to, a lot of times, I don't know that that plays into the suicide so much, but I know that that is a big issue with our homicide rate here in town. With our young adults, they keep getting in motor vehicle accidents, whether it's one car or multiple cars or a motorcycle injury. Suicide is also still an issue here. So our role in prevention to recognize depression and to screen for it and to treat it. We just need to see whenever there may be an assessment piece that indicates a potential problem, we do follow up on that. If they have physical complaints, weight loss, sleep disturbances, digestive disorders, all of those can say, hey, there's a problem and we need to look into it a little bit further. And then any type of isolation. So if they decrease their social and work roles, just trying to withdraw and isolate themselves, we need to follow up on that and just make sure that they are okay. With middle age, accidental deaths, motor vehicles, once again, we're driving too fast and too crazy out there. But with our middle-aged adults, if we think about like over the age of 40 here, decreased reaction time, decreased visual acuity, a lot of times patients and just individuals in general, they may not be able to see as well at night as they do during the day, so they may not need to drive at night or when it's raining, when driving, when conditions change out in the environment. And a lot of times with the night vision, it has to do with all the lights. So from the oncoming traffic, from overhead lighting at, just lighting the roadway so we don't have crashes, it's very harsh and can cause blurriness and disturbances with their eyesight. Falls and burns also come into play. Falls, if we think about balance and just coordination there, and then burns with decreased sensation. Poisonings, a lot of times unintentionally, and this can be with just a lot of, sometimes it may be just too many medications being mixed, just that polypharmacy. Drownings can also happen. Occupational injuries as well, just because this is our workforce, and so just to make sure that they are being safe and not cutting corners. Older adults, I think I already mentioned this, the night driving, so accommodation to light is impaired for at night. Peripheral vision, so being able to see on the sides diminishes, so they have to turn their heads really well. Driving in fog is no good for any of us, but it especially should be avoided if they're having sensory issues with vision. Fires, forgetting that things got left on. That happens just in general, not just for people who have dementia. May not extinguish their cigarettes completely, especially if they may be smoking and it is in the evening and they may fall asleep. I know we have a lot of house fires in the winter months just because people may not have central heating, and so they may be using space heaters, and they may get too close to curtains or other things that are very flammable materials. The risk for wandering, this comes more in with our Alzheimer's or any dementia kind of like that. Analgesic sedative use, but that will cause patients to become more lethargic and confused. So a lot of times people may use things to help with chronic pain or acute pain. or maybe to help them relax, decrease anxiety, help them to fall asleep, things like that. So we just need to make sure that they are taking those medications appropriately and as prescribed. The suicide rate increases, and at this point, for older adults, they are more serious about their suicide. It is not an attempt to get attention at this point in time, and so these are generally more violent suicides, gunshot wounds to the head, hangings, things like that. And then across the lifespan, we always need to be aware of violence. So whether it's child abuse, domestic partners or intimate partners, older adult abuse, where you may have children abusing their parents or just whoever it may be. And so this just is a great opportunity for us when we do our assessments to ask those questions, to ask questions specifically to our patients, and only when only our patient is there. They're not going to say anything if the one who is causing the violence or the abuse is in the room with them. So just an opportunity for us to be their advocates and to refer them. We don't have all the answers, but we can figure out where those support groups and resources are for them and direct them in that direction. Another thing to help us promote safety in the healthcare setting, and this goes along with that to err is human from the Institutes of Medicine, but avoid focusing on blame. So we're not looking to blame anybody, to find that scapegoat, to say it wasn't my fault, it was hers. That's what the school-age child will do. Hopefully we are more mature developmentally, and we can just look on, okay, what were the circumstances around this injury or this error, and figure out how can we help prevent it in the future. To develop trust, to share experiences about safety, just to have those conversations, and to trust that we can reach out for help and that people will help us appropriately. And then just to be active in preventing. Medication errors are huge. There's a lot of different reasons why they happen, but we just need to, when we get into that in clinical, we go through all of the rights, and you will think that we are a bit overbearing as your clinical faculty, and that check off, but it really is just to keep you safe, to keep your patient safe, and to make sure that we don't cause any errors. Communication, it cannot be stated enough. That is so important. Open communication. For falls specifically, infants and older adults are particularly prone. Remember, our infants are figuring it out, not like the 0 to 3 month stage, but after that when they start waddling around. And older adults, just that balance and coordination decreasing. Most of these are going to occur in the home. There is a fear of falling in those who live alone. Once they have fallen once, they may become even more fearful. I know that there was a gentleman, he was older, he fell outside, and he was not in contact with any of his family for a day or so, or maybe it wasn't even a day, but several hours, but he was just laying there outside. I think the family finally, or someone kind of checked on him when they couldn't get a hold of him. But since that, he was afraid to walk outside. He was walking to the mailbox to get his mail. And from that point, he was very fearful to leave his home. So it had a huge impact on his life and how he interacted and his social interactions and just that mental health that we need social interactions to help us be complete and healthy. Joint Commission standards. We need to assess and manage the risk for falls. You will see a lot of fall risk bracelets and fall risk signs, and bed alarms will be on, and bed in low position, side rails up, whatever it may be, just to help manage these risks for falls. We will do a fall risk assessment, and in the assessment class, in relation to, I believe that's more with our musculoskeletal, but a lot of the questions that are asked is, what is the age of your patient? What medications are they taking? Are they taking medications such as blood pressure medication, antihypertensives that are going to lower their blood pressure and maybe increase their chance of having orthostatic hypotension, which may then increase their risk to fall. Number of diseases, their ability to see clearly, have they had falls in the past, what is their muscle strength, and there is a get up and go test, and I'm 99% positive that that is one of the assessment tools that we have in the musculoskeletal. We'll tell our patients, call us before you get out of bed. We will be happy to come and help you. We will put bed alarms on their beds or chair alarms on their chair if that's where they're sitting, so that it will beep at us and we will come running if they get up without. And then just knowing what your role is to help prevent these falls again. So orienting the patient to their surroundings, tell them to use this call light, tell them how to use it, push this red button that has the nurse hat on it. Carefully assess their ability to ambulate and transfer, so once again their strength and mobility there. Provide walking aids and assistance as needed. On page 652 there are some practice guidelines, and it goes through all of these things. Other things would be maybe having non-skid socks on them at all times. I think that might be on the next page, so let's look. Supervise them, especially at night. Encourage them to use the call bell. Place bedside tables and overbed tables near them so they do not have to reach too far. And so if they have water in their cell phone and their glasses and whatever else, just put that on their bedside table and have it right next to the bed so they do not have to reach too far. Low position, wheels locked. Use the grab bars when they're toileting. They can call when they are done. Here it is, the non-skid footwear. Those would be our beautiful socks with the rubber soles on them, or like lines on them. Keeping the environment tidy, so that means, make sure there's no cords, make sure that there is, just not a lot of furniture or randomness around. And then when this is hospital, but then when they get home too, making sure that it's a clear pathway, furniture's out of their walkways, throw rugs are out of their walkway, maybe to have night lights placed strategically so that they will not run into anything in the middle of the night. Electronic devices rather than side rails for the confused client, because that would be electronic devices is your bed alarm, rather than pulling up all their side rails when they are confused, because they will still be confused and they will climb over all of these side rails, or they will wedge themselves somehow in between the side rails and get stuck. We may have other entries and they are still, if they're still climbing over, they have an increased likelihood of falling from that than if we left one side rail down and they could easily swing themselves out, but as soon as they sat up and changed their weight in the bed, then that alarm would go off. And then also use lifts if they're dependent. Here are fall precautions. What do we need to do? This is on page 651. And then I am not going to touch on this at all, other than saying I think we covered it well in clinical. If you have questions, let me know, but we do need to know how to appropriately use bed exit and chair exit devices. These, depending on what facility you're in, will depend on which brand they use, so they may vary slightly. So we'll touch base with those in clinical. Seizure precautions. These are just the different types of seizures that you may see, a partial, generalized, or a grand mal. But regardless of what kind of seizure you see, this is what we are going to do. The big thing here, if you look under delegation, the RN needs to always stay with the patient. We don't need to restrain the patient. We need to protect their head. We should put them in a lateral position, so on their side, so that if they are having secretions, that they do not aspirate those secretions and then we have a pneumonia or other issue. Also to make sure that their tongue stays out of their mouth. Do not put anything in their mouth to keep their tongue from falling back and blocking their airway. We want to observe the progression of the seizure, so watching the sequence and the limbs that are involved. Apply oxygen either by nasal cannula or mask if they need it. Suction their oral airway, especially if they start to vomit or have any excessive secretions. If they have an anticonvulsant ordered, we want to give it. We want the seizure to stop, right? And then we want to assist our patient to a comfortable position, reorient them. They will likely have no clue what happened recently. Reassure them. Provide hygiene, because if you just threw up on yourself or you had a lot of secretions, you would probably not feel too clean and want to take care of that. There is some sample documentation about how to document a seizure and what you did at page 655. Also some lifespan considerations, which they're on a slide here in the next little bit. With safety hazards related to scalds and burns, if we think about the age group that this is going to come into contact with, are infants. Toddlers are probably going to be the most prone. So these pot handles, remember that we're going to turn them inward. We're not going to leave them dangling or just a temptation hanging over for something for the toddler to reach up, and either the handle itself is hot or they are going to grab that and dump out all of that hot water on top of them. Electrical appliances, the same thing. Anything that may have a cord dangling, they will pull the cord and that appliance will fall over on them. If it has a hot liquid in it or an oil, then it can potentially burn them. And then that excessively hot water, with our sensation not being able, the infants and toddlers maybe not being able to tell us that the water is too hot and having accidental burns, or even our older adults with decreased sensation and not being able to tell if the water is too hot. With fires, just having a plan. RACE and PASS are the two acronyms you need to know. RACE, if we're in a hospital and there's a fire, what do? We rescue those in immediate danger. We activate the emergency response system, so 911, fire department, whoever that may be. We confine the fire as best we can, so closing doors, and extinguish the fire if we are able. If it is a small fire, if it's too big and out of control, we will not be the hero of the day. But if it is a smaller fire and we feel like we have a fire extinguisher available and we may be able to put it out, then that is what we will do, and we will remember the PASS acronym now. So we will pull the pin out of the fire extinguisher, aim at the base of the fire, squeeze the handle of our fire extinguisher, and sweep from side to side until the fire is extinguished. For home fires, just teaching fire safety. So if you use candles or matches or lighters or whatever it may be, just making sure that everyone in the home knows how to do that safely. Having emergency numbers, whether that's 911 or teaching that in the memory, or in a cell phone to have ICE, that in case of emergency contact, so they will know who to contact if there is a fire. Making sure your smoke alarms are working properly, and not doing like I have done before, but changing your batteries in your smoke alarm every year. So not every time that they beep at you, whenever that may be, to let you know that it's low, but picking a special day in the year. So January 1st, your birthday, a holiday, an anniversary, whatever it may be, one day every year that you will remember, and that you will change your batteries and your smoke alarms on that day to keep them working. Other things with home fires, making sure that the family has fire drills so everyone knows what to do in case of fire. It is so much better to plan and prepare and be ready for something that's never going to happen, rather than to have everyone freak out and not know what to do and just kind of stand there in a state of shock. Not the best option. Fire extinguishers are a good thing if people can have one in their kitchen or wherever you think a fire may be most likely. If there is a wood-burning fireplace or something like that in the home, and maybe there. If possible, all of these things. Close the windows and doors to keep you in the fire, to have a barrier between you and the fire. If you're trying to escape, covering your mouth and nose and bending over with your head as close to the floor as possible. All of that to help prevent the smoke inhalation and to help you escape the fire without passing out somewhere in between where you are and getting out of the house. Carbon monoxide poisoning, so any gas-powered vehicle, so cars, also the lawnmowers or any kerosene, wood-burning stoves, they all emit carbon monoxide. prolonged exposure to this can cause you to pass out and can eventually lead to death. They have carbon monoxide detectors, so if we have one in our home because we have a gas stove and oven, just in case, which has happened before. It has accidentally been turned on and the gas has leaked. So just to make sure that people, and it does have a smell, they put a smell in with it because carbon monoxide is odorless and tasteless, but the gas company will put, I forget exactly what it is, but put something in it to make it more odoriferous so that you will notice that it is a gas leak. Or, do not crank your car out to let it warm up when you have the garage door closed and no other ventilation, things like that. With poisoning, there's some client teaching on page 657 that might be helpful to look at. For kids, we want to childproof the environment, so put up all the laundry pods. Make sure that the medications have childproof tops on them. Locking up, doors that may have the harsh chemicals behind them. For adolescents and adults, if they live in the woods, if they go camping, making sure that they know what to do if they have spider or scorpion or snake bites. And then also these, drugs that they may or may not be using for recreational purposes. How does that affect them? And just making sure that they understand and have good knowledge. For this last one, this accidental ingestion of toxic substances, I think about people with dementia, and then those individuals that have a knowledge deficit, just to educate and to take extra safe precautions for things when we have confused patients. The last thing about poisoning, making sure that you have a good number for the Poison Control Center. As far as educating the public, we need to be able to have them identify what the specific poison it was, to know to contact the Poison Control Center. And then it's really good to keep the person quiet and position them in a way to avoid aspiration. So a lot of poisons will cause vomiting, and so we just want to make sure that they are in a position that they will not aspirate if that happens. Suffocation, choking, that asphyxiation, a lot of times, once again, this is with our toddlers and those clear plastic bags. They're just being curious, exploring their world, and we do not want them to explore their world when it may lead to them not being able to have air. That universal distress center of both hands covering the neck, but remember that there would be absolutely no air moving in or out, so no sound or noise. At that point, we would want to do the Heimlich maneuver. We want to try and remove the obstruction immediately, try to open up the airway for our patient. And if the Heimlich maneuver is unsuccessful, then you would want to then begin CPR if they do go into an arrest, respiratory arrest or cardiac arrest. In minimizing noise in the hospital setting, so just being mindful. We're not going to be loud and boisterous in the hallway. We are not even if we're just having a celebration. Just trying to keep that noise to a minimum. We will respect quiet time hours for our patients, especially when it's in the evening time, so that they can rest. And then just in general environment, we think about our community in general. I think about the work environment, protecting hearing as much as possible. So does somebody work in landscaping where they're working with heavy equipment and that might be very loud? Do they need ear protection there? If they work at a car wash or wherever, just to have those head muffle, ear muff kind of things, so just to protect their hearing. Hearing, a noise can cause physiological effects too, which can then in turn turn into something else. So that just that increased heart and respiratory rate, increased muscular activity. So if you think of just stress and anxiety, noise can induce that sometimes. Sometimes nausea and oftentimes hearing loss, which then can turn into one of those long-term sensory deficits that may not get better with time. And so then we have to figure out how to cope and compensate for that. With electrical hazards, just making sure that we are avoiding shocking, that the equipment that we used, that wires are not frayed, that they are properly grounded. If you think of most things, they have 3 prongs, and that large prong is to ground. And that faulty equipment it is a safety, electrical shock risk, a fire risk. And if patients bring equipment into the hospitals, typically we have to have it checked out to make sure that it is safe for them to use, that it's not going to put them at an increased risk for shock or fire while they're on our watch. With the electrical hazards, we can receive, your patient, hopefully not you, they can receive burns. They could have muscle contractions. They could have cardiac and respiratory arrest. So just to make sure machines are in good repair, rubber sole shoes are good as they do not conduct and stand on a non-conductive floor surface, something that is not wet. And then if you do have a patient or you're in the community and someone has received an electrical shock, you want to make sure that they are no longer in contact with that electricity before you touch them, or else you are putting yourself at risk of electrical shock as well. With firearms, no big surprise. Ideally, all guns would be stored in locked cabinets where the keys are inaccessible to the children. Bullets are separate from the guns. That we are educating our children to never touch a gun or stay in a friend's house where guns are easily accessible. We need to teach our children, especially those that have not differentiated just because their brain is not fully developed and can understand the difference between fantasy and reality, that you never point a gun at anyone. Ensure that the firearm is unloaded when someone who knows what they're doing is handling it, and especially do not mix alcohol, drugs, and weapons. Not the best idea. Other things, ammunition separate if you are cleaning your firearm, and then to have the firearms inspected at least every couple of years. Radiation, this can be something with us, especially since if you think about MRI machines, X-ray machines, we want to limit the time near the source. If you work in an area where you are exposed to radiation or have the potential to be exposed to radiation, you'll wear a little badge, and it will keep up with how much radiation you're exposed to and will help you objectively limit your time near the source. You want to provide as much distance as possible. Use shielding devices. If you've ever had an X-ray or been with someone while they receive an X-ray, you'll know that you cover up areas. So my daughter, when she broke her leg, they put a shield, basically from her neck to over her pelvis, just to hopefully to shield the radiation from all of her internal organs and her thyroid, and just focus on her bones and her legs. And then, of course, no one else can be in there with her. You have to step behind step out of the room or behind a shielding device of a wall that has special things in it. Anyway, a really thick wall. All right. Be familiar with the agency protocols. Bioterrorism. I feel like we've done this, but just the whole disaster planning. To mitigate or minimize loss, be prepared, know how to respond, recovery afterwards. In Chattanooga, we have an annual disaster drill in the city of Chattanooga, where hospitals and the fire and the police departments and a lot of different agencies will come together to practice in a community-wide disaster drill, just so that in the event that something happens, it will not be, oh, I remember doing that, but it was so long ago I can't remember what I'm supposed to do. Just to kind of help keep it fresh in the brain, keep our skills sharp, and so that when there is an actual disaster, we will respond appropriately. trying to think if there's, I don't really know that I have anything else to add to this. Equipment and procedure related accidents. It is important. This is why we have our incident reports, just to make sure that we can properly document and do a root cause analysis on what those issues are. Restraining. Alright, ideally, the only two reasons you would restrain per Joint Commission and CMS, which is the Center for Medicaid and Medicare Services, had to think about that for a minute, is to either, one, avoid and prevent purposeful or accidental harm to the patient, or two, do what is required to provide medically necessary treatment that could not be provided any other way. So, if we want to restrain them if they are going to cause harm to themselves, or we want to restrain them so that we can actually do what we need to do to provide them physiological care. So if they are pulling out their endotracheal tube that's connected to the ventilator and we cannot provide adequate oxygenation for them, that would be a reason to restrain them so that they would not be able to pull out that tube. Same thing for feeding tubes or IVs, things like that. Physical restraints, they will restrict movement. They are not removed very easily, and so we need to be mindful. That's just the physical restraint. Chemical restraints, sedatives, neuroleptics, psychotropic drugs, anxiolytics, those can be considered chemical restraints. We need, as far as legal implications, they do restrict the individual's freedom. The orders will need to be renewed every day, every 24 hours. The order has to give a reason why it is medically necessary. You cannot have a PRN order just to use restraints as needed. And we work really, really hard to avoid restraints. And like I said, restraints, it's our last ditch effort. I mean, after we have reoriented our patient, after we have had family members stay in the room with the patient, if they are able to, we move them close to the nurse's station, we keep their door open and provide a watchful eye as best we can. But when all of that is just not working out so well, then we may resort to restraints. Typically, long-term care agencies will not accept patients that are being restrained just because they will not be able to restrain them in the long-term care facility. So we need to figure out alternate ways for that. I remember I had a patient, his restraint that we had for him was a bed tent. He kept crawling out of his bed. He did not speak English. This was when I worked at the Rehab Institute in Chicago. And so it was just a tent. It was basically like just a fabric cage to keep him in the bed. And what we ended up doing so that we could end up placing him in a long-term care facility once we had done all the inpatient rehab that was helpful and beneficial for him, we ended up just having him a mattress on the floor because he was crawling out, and it was just because of falling was his biggest issue. So when we realized that he would stay put in his room, we just put a mattress in the floor of his room. It was different, but that was how we worked around trying to get out of the restraints and to prevent him from falling, and then be able to ultimately discharge him from the acute care rehab to a long-term care facility in the community. Along with this, don't really have anything to add to what you see here, nurse applies restraints, but we do need a primary care provider, nurse practitioner, somebody with a degree higher than just RN, to see the patient within 1 hour of applying the restraints and to actually give us a medical order. That medical order is only good for 24 hours. Legal implications of the restraining, the written restraint order for an adult, valid for only 4 hours. If it's a medical need, then it is good for 24 hours. And we do need to be able to have continual visual and audio monitoring of the client if they are restrained and or secluded. Also in Chicago, we had video cameras in certain rooms so that we could monitor those patients remotely, and someone was always watching that just to make sure that they were not becoming entrapped or entangled or causing additional harm to themselves. Possible injuries that can happen with restraints, just want to throw that out: muscle atrophy, bone loss, contractures, pressure ulcers, constipation because they're not able to drink enough on their own and we forget to offer them fluids, not good, decreased appetite. So when we assess for restraints, we want to make sure that we're checking their hygiene status, that we're checking their skin and hydration. We're making sure their nutritional requirements are met, their elimination needs are met, if they have any pain, and then also their vital signs, just throwing that out. This is on page 661, and this is everything we're going to do before we restrain them. The 5 criteria for restraint. We want to find a restraint that will restrict the client's movement as little as possible. It is safe for the patient. The other 3 things out of 5, that it does not interfere with their treatment or health problem. It is readily changeable, especially if it becomes soiled for any reason. And it is discreet as possible. Restraints can be embarrassing, and so we don't want to cause any mental trauma that is unnecessary. There are practice guidelines for how to apply restraints on page 662, and I believe that this was pretty well covered in the Skills Lab Day 2. Evaluation, this is our last piece in the nursing process. Just know these desired outcomes. So what are we looking for? They need to reflect that the patient has acquired some knowledge about the hazards, that they are implementing behaviors that are, promoting safe practices, that they are showing us skills that they can perform in the event of an emergency, things like that. On the next 2 slides after this, the desired outcomes involve client being able to ... Those are really great ideas for goals that you could have. I just want you to make sure that your goals, when we do get to the care planning, that your goals are very specific and that they are measurable. So we'll talk a lot more about that, but just know that the goals that they give you in this fundamentals book, it's a great starting point, but it is not your end point because they are usually not very specific or measurable.